Hello, I am Eduardo Albéniz. I belong to the endoscopy unit of the Complejo Hospitalario of Navarra, Pamplona, Spain. I also belong to Navarra Biomed Research Foundation, and I have the pleasure to coordinate the endoscopic resection group of the Spanish Endoscopy Society, in which we perform EMR, ESD, POEN, GPOEN, STER, etc. Recently, our manuscript entitled Clinical Validation of Risk Scoring System to Predict Risk of Delayed Bleeding After EMR or Large Colorectal Lesions has been accepted in gastrointestinal endoscopy. Delayed bleeding is the most frequent major complication after EMR or large colorectal lesions, with an incidence about 3 and 10%. Large lesion and proximal colon location are risk factors for delayed bleeding, but the role of the other parameters are controversial. Two models designed to predict delayed bleeding were designed. The model from the endoscopy resection group of the Spanish Endoscopy Society included the following variables: age, SAA classification, aspirin use, lesion size, complete closure of the mucosal defect, and proximal location. In a second model, the Australian Colonic Endoscopic Resection Group, the ACER, risk score included the absence of adrenaline injection solution, major comorbidities, lesion size, and proximal location. Although both series include a large number of patients, the independent variables resulting from these studies don't tally, and neither model was validated by other working groups. In the present study, we aim to validate both scoring models. The secondary aims were to update these models and develop a new improved model. We assessed the performance of these two models in the original versions using three large prospective cohorts: the pre-2015, the post-2015, and our total cohort. In addition to the two original models, two updated versions were assessed following the recommendations in the literature for risk prediction models. Finally, a multivariate logistic regression was used to create a new model that included variables significant in the univariate logistic regression analysis for the post-2015 cohort and/or were included in the Spanish and Australian models. The post-2015 cohort consisted of 1,034 EMRs of large colorectal lesions performed consecutively in 977 patients. Delayed bleeding occurred in 45 patients with an incidence of 4.5% of delayed bleeding incidence. We identified the following variables as being associated to delayed bleeding: location proximal to the splenic flexure, location proximal to the hepatic flexure, antiplatelet use, anticoagulant use, warfarin, azinocumarol of dabigatran, and high difficulty of the EMR. If you read our paper, we performed a really complete and complex statistical analysis. So we have the original version of the Spanish and Australian scores, the recalibrated versions, the re-estimated version, and the new model with different categories of antiplatelet and anticoagulants. All of these models we validated with the post-2015 cohort, the pre-2015 cohort, and our total cohort. So I left you the main conclusions of our work. Overall, the performance of the original Spanish and Australian model was fair. However, the recalibrated and re-estimated models achieved better performance, but it was still suboptimal. These results suggested that the previous model needed refinement before recommended use in clinical practice. For this reason, we developed a new model that predicts delayed bleeding with a reasonable accuracy. This one includes 4 easily identifiable variables that can be assessed before performing any procedure. The first one is major comorbidity with 1 point, size greater than 4 centimeters with 2 points, antiplatelet or anticoagulant use with 3 points, and lesions located proximal to the hepatic flexure with 3 points. Notably, the new model eliminated certain variables that weren't significant in the different cohorts: clip closure, age, and adrenaline use in the injection solution. The first 3 variables of our score are non-modifiable, and the last one may be modified depending on the risk of thrombosis. The new model provides acceptable area under the curve across cohorts. Calibration plots were also more stable across cohorts and model versions. The discrimination slope were more consistent. The probability of delayed bleeding in the highest risk category was most stable, which suggests better detection of high-risk patients. This model is a useful informative tool that predicts delayed bleeding risk in 10 groups, scores from 0 to 9, and risk of bleeding for 1% to 20%, placed in 3 categories: low risk, medium or average risk, and high risk of bleeding, which may allow taking preventive measures for each patient based on their score. Now, we have 2 randomized controlled trials about clipping in large lesions. Therefore, we can use our tool to better selection of high-risk patients and to perform complete closures in this indication. As we mentioned before, we can tailor anticoagulation depending on the delayed bleeding risk score, and it can be used for logistics of the patient, for example, to stay close to the hospital during the first week. And finally, the new model may improve selection of candidates for inclusion in clinical trials, as we done for our paper about clipping. Of course, our work has limitations and must be validated by other working groups, but we can consider that it's the best option for clinicians and endoscopists to know about the delayed bleeding risk of every patient. Thank you for your attention. I remain at your disposal, and of course, we are open to any scientific collaboration. Thank you very much.